I'd like to welcome everyone to our second Ungerleider Palliative Care lecture. Tonight's speaker, B.J. Miller, is pretty much the poster child for what makes palliative care such a satisfying specialty to be part of. I'm just going to give you a brief background on BJ's credentials. BJ went to undergraduate at Princeton, where he studied the relationship between music and art in the 20th century. He subsequently went to med school at UC San Francisco, did his residency training at the Medical College of Wisconsin for internship, and then realized what he was missing again and came back to California, where he did his residency at Cottage Hospital, including a chief residency year, and then went back to the East Coast to Harvard to train in palliative medicine at the joint program in palliative care at Harvard. He subsequently traveled back cross-country again, where he joined the faculty at UC San Francisco. And for the last several years, he has been the executive director of the Zen Hospice Project in San Francisco, where he really has been transformative in taking Zen Hospice to an entirely different level. Beyond his academic credentials, BJ has been recognized with numerous teaching awards at UC San Francisco, was named as a Soros Foundation Project on Death in America palliative care clinical leader. He received a clinical leadership award in 2014. And most recently, in 2015, he was invited to Vancouver, where he gave a TED Talk on transforming palliative care. So I'm really looking forward to this lecture on aesthetics and its role in palliative care. So, BJ.
Thank you, Ken. I think I'm rigged. Thank you, Ken. Real pleasure being introduced by you, someone I admire and respect very much and who I get to work with, too. And thank you, Drs. Ungerleider, for this lecture series and all that you and your family are doing for palliative care at CPMC. It sounds very exciting. So, nice to see you all, some familiar faces. I warn you, this talk there's zero data, okay? There's very little medicine per se. One of the joys of working in palliative care is that while medicine's a piece of the puzzle, it's certainly not the whole thing. And that's, for me, a thrilling piece of the puzzle. And a way in, and we'll talk more about this, but a way in for so many other subjects that are important to us as individuals, and then we get an excuse to make them important to us professionally. So it is for me, an art. Well, I won't foreshadow things too much. Let me just jump in. So the early slides are just sort of some prompts for us to kind of get in the right headspace around the subject. Living, dying, I'm watching a lot of hospice agencies start to market themselves and say, oh, it's not about dying, it's about living. And some of that's marketing, and some of that seems very, very real. Cicely Saunders herself would talk about the goal of being sort of living fully until you die. And because, of course, dying people are still living. Right, so there's a lot to very real about this entwinement, and I think the more we look at this subject of our mortality, we see how entwined it is with living, not some anomalous mistake, very much part of the deal. So this relationship is part of what inspired this subject for me. Meaning, there's this suite in Articles of Confederation of Palliative Medicine. There's talk, existential suffering, existential distress. This plane that is pretty much, it's not very well defined anywhere, but it's pretty much anything that's not a symptom that we can track, like anxiety and depression or pain. If something's still bothering you, we just call it existential. So if we kind of, it's a diagnosis of exclusion in some way, which is, okay, at least it's a toehold. It's a foot in the door for us to upload all sorts of things that don't make their way to traditional medical science. And this is where things start getting really exciting. So meaning and meaning making is a big part of the picture here. And this idea of self and other, where are the lines? I mean, there are, of course, by way of our bodies, we are separated one from the other. But even that's starting to be sort of debunked a little bit through things like mirror neurons. And I can't I can't relate the research to you, but there's this sense that we're finding excuses to realize that, in fact, we affect one another. In fact, we may be, in some ways, part of one another. We certainly are a part of one another's experience. So the lines between self and other get kind of blurry, which is also very exciting and very interesting. And it's also a big part of the problem for those of us who work in the field because of, it's hard to know sometimes where I leave off and my patients begin. And there's a sense that there's never an end to our work. And I think burnout is a big problem because of this. And the more we invest ourselves in our patients' care, in some ways the better for our patients and their families, but sometimes it can be at our own peril. So this is very much a double edge, and it's hard to define. It's hard to find where that line is. By the way, how many folks here are in practice palliative medicine on some level? Great. Okay, and how many people here are clinicians? Okay, not everybody. Okay, good. I saw that last hand come up. Okay. This thing, I like to think about this one. I wish we as a society would get a little more thoughtful. Discernment, seems to me like a really powerful muscle to exercise, to notice distinctions, notice differences. But somehow or another, we sometimes trip from discernment into judgment, and we lay values on people and things. So it's just a call out here in these early slides again for us to maybe think about exercising discernment and falling shy of judgment, especially where it relates to our patients, perhaps even ourselves on some level. Walks like a duck, talks like a duck. So anyway, I personally, I think we do a disservice. It's interesting in the Bay Area, and people have written about this, how because we're such a diverse society, that sometimes it doesn't feel okay to acknowledge differences between us. That somehow feels like discrimination. Well, I think that's a real shame, because so much of the joy in our lives are due to the distinctions and differences, and so much of the interest. And by the way, right, light and dark need each other. We can't see anything when there's no contrast. So there's much to say about this. I just wish we would, as a society, watch ourselves and mind the judgment. I like to exercise this muscle in the aesthetic domain with art and objects that don't have feelings for me to hurt. I can get really ruthless with my house, and as I design it and decorate it and move things around, that feels right to me. When I start applying that to my friends and family and strangers, then things get a little squirrely. Okay, this one, attention. How the heck do we pay attention? How do we hold attention? Ourselves as caregivers and human beings, but then also with huge caseloads, how do we hold attention? How do we stay present with our patients when there's so much going on? In a world that's increasingly busy, or at least increasingly chaotic, the volume of things that comes before us is huge, to the point where it just can shut us down. So it seems to be harder and harder for us to pay attention. And it also seems to me, anyway, that very few things these days reward us for paying attention. The harder you look, the closer you look, things start falling apart. Especially in the material world, things aren't designed to last very long. They're designed for a splash and to be disposable and we throw them away, whatever else. But our attention often does not seem to be rewarded. And it's hard to find a safe place to exercise this particular muscle. For me, the aesthetic domain is a really sweet place to really reward ourselves for paying attention. this continuum of being and doing, this comes up at Zen Hospice a lot. And one of the things that's so neat about that organization and working there is we have this huge volunteer army who are not there as professionals. They may have professional backgrounds in this or that, but they are there to be, most importantly. And I think a lot of us realize the power of not running away from people, just simply non-abandonment, I think is a fundamental tenet of palliative care. But it's hard to do. To hold silence, to sit with someone, to be in the presence of someone suffering is very difficult. And for those of us who've gone through medical training, it sort of tends to push us to go do something, to fix it. That's how we respond, rather than just sit there and be with someone. And I don't think, again, as a society, I don't think we're rewarded for just being. We're generally related by our accomplishments, the things that we achieve, the things that we do. And, you know, California Healthcare Foundation did a survey a couple of years ago of the general public about what was important to them as they thought about their own death. And of the top 4 things, 2 of them had to do with being a burden. The other one was pain, and the other was being at peace spiritually. So of the top 4, you know, only one is really a medical issue of note. But this other piece about being a burden to the people we love and to society, because there isn't a place to just be. Once our role has dissolved as an employee or as a colleague or even as a parent, there seems to be no place for us. And I've watched many of my patients just want to get the heck off the planet because they feel like they're just taking up space, wasting space. So maybe we as a society could help, especially on this existential plane, to carve out ways to just be and reward that for its own sake. And I think, you know, you think about the phrase art for art's sake, and there's something to take from how we are with art, and I'll get into that a little bit further. Okay, being, more about being. Well, this is meant to just relay the fact that we are relational beings as a species. We are, I probably don't even need to say more than that, except to just note this being in the world, i.e. being in space, and then being in the moment, being in time. And we as a species on this planet anyway, as far as we can tell, are largely ruled by space and time. All right? But the bigger point here is that this is a relationship. And we can have relationship with objects as well as human beings. Okay, flesh. So at Zen Hospice, sometimes I'll get into trouble because I'll talk with some folks who are practicing or strict Buddhists, and sometimes we can't even agree that we all die. And it's very flummoxing conversation because they'll say no birth, no death. And I thought, well, okay. It's hard to say that to a person who doesn't share that belief system. Oh, you're not, don't worry about your death. You never were born. You're never going to die. I mean, it's almost a useless, anti-useful thought for most people. They don't share that sort of system of beliefs. So that aside, I think we can all agree that it is the body that dies. This body that inhabits my life, this life, will die. Anyone want to argue that one? Some people would. So I think it's just to draw our attention, as I kind of find it interesting as we think about mortality across culture and the sort of subjective space. One thing we can probably agree on is largely that the body dies, and therefore drawing some attention as the highest common denominator of our work together to the body and the experiences of the body make a lot of sense. And by the way, I mean body in this larger sense. It's not this Cartesian mind versus body. To me, the body inhabits the mind as well. So to ground ourselves, literally and figuratively, ground ourselves in the material world, because that's what we got to say goodbye to. And the body is the thing that's doing the living and the dying. Okay, so this is just a personal neurosis. I mean, I think words get way too much power in our world. They're our chief means of communication. Is very useful. My senior thesis at Princeton was all about how, the subtext was really about how words just, I got to watch myself. I can go off on a big tangent here. But let me just say this, that one of the things I love about the art world is it can say things that words and normal prose can't. And if communication is such an important part of our work together, let's look to the world beyond words. There's so much more to say without words. So this is just another access point for this aesthetic dimension in the arts. Okay, so we know this word, But not a lot of us, I don't think, I won't speak for you, but there's not a lot of understanding about the word aesthetics and what it actually entails, what it means. So here's just this pulled out of a magazine on an airplane. And you'll see aesthetics these days often like aesthetic dentistry and things like that. And the common parlance is aesthetic and beauty are sort of one and the same, entwined. And here's, in the name of aesthetics, here's a beautiful woman in a lovely gown on lava rocks. I hope she's not wearing heels. I don't know. So it's very discombobulating, very strange. But okay, I think they're trying to tell us that aesthetics has something to do with beauty. Okay, and there's Nefertiti, this symbol of the American Plastic Surgery or Cosmetic Surgery Association. But maybe we can do a little bit better than that. So aesthetics, even the Webster's Dictionary starts pointing us to beauty immediately. And again, though, I still think this is a little misleading. So I won't even ask. If those dates mean something to you, I would be just shocked. But it is, in fact, the lifespan of this guy, Alexander Gottlieb Baumgarten, who was a man who gained no fame otherwise except for his undergraduate thesis that initiates, that starts, that gives us the word aesthetics. All right? And he gives us the beginning of a philosophical idea around the aesthetic domain. So, this is in Latin, but there it is. There's the word. It's very interesting. It's not that I've read this, but I know that the word beauty is nowhere in his thesis. He is not talking about it in this reduced format. He brings the word. He gets the word from Greek, even though he's writing in Latin. So aesthesis is the senses, perception by the senses, feeling, some sensation, observation, intuition even, gut, the things that we feel, as opposed to pure thought. All right? So yeah, while the senses entail beauty, that's part of the piece, a piece of the puzzle, it is by no means the whole story. All right? So I'm trying to get us to expand our idea about the aesthetic domain to include sensations, feelings that, sure, beauty is one of them, but there are many other ones. I think it's telling that our society goes right to beauty. Okay, now another way, I got to give credit to my buddy Justin Burke for a lot of these slides, by the way. He's in this. You'll see him there in a minute. I could never figure out how to do all this. But so another way of understanding the aesthetic domain is by its antonym, a word we all know very well, anesthetic. All right? So anesthetic, that's what you got a tooth to pull, you go to the dentist, you get a shot of Novocaine to what? Anesthetize, take away feeling. All right? So I think that's a kind of a telling, quick way into our subject, especially for those of us in the healthcare world who spend time in the hospitals, which as a rule, the highest high you're going to get in the hospital is numbness. It's not a place that rewards your sensory life. Although it's telling. You guys, are you aware of this organization called Plane Tree? Yeah, so they got their start, I believe, here at CPMC.
They had a Plane Tree unit for years.
Yeah. So that group, and I can't remember the woman who founded it, but they really ran with this idea that attending to the life of the senses is a healing act, is a therapeutic act. And that started in this very hospital. Okay. So, anyone know this? This is a picture, where this picture is meant to be? What's that?
Is that a Harvard operating room?
It is.
The ether dome?
There you go. Right. So the ether dome. So right on. This is, and by the way, this is where we as palliative care fellows at Harvard had to give our grand rounds in this very room. It was a fascinating place to be. But 1846, ether comes on the scene, and all of a sudden you could anesthetize someone, and you could start doing all sorts of things to a body when it's anesthetized. And you can make the argument, medical historians, you might make the argument that this is where, in the coming ensuing decades, this is where science and medicine started coupling. And this is where we started objectifying the body. And we could think about the body and do things to the body thanks to ether that we could not have imagined if we were to be sentient beings. awake, alive. So I'm not suggesting that medicine went awry with the invention of anesthetic. As someone who's had a lot of surgery, thank the gods for anesthesia, but I'm just saying there was a departure there away from the embodied experience, the sensory experience of being a human being. Okay, this gets us to Immanuel Kant. So he's a big famous Enlightenment guy. He gives us a critical philosophy, and there are 3 books: the Critique of Pure Reason, Critique of Practical Reason, and then this, the Critique of Judgment. And half of this very book, the 3rd book, Critique of Judgment, is all about aesthetics. And he's the one who takes Baumgarten's word and runs with it. So I just place these in here for those of you guys who might want to read more. It's just there's a lot to Kant. So in his text, he alights on this word to describe the aesthetic domain, Belebung, which is gets at this idea of quickening, so enlivening, animation. All right, life. Beleben is the German root to live. So in his world, he starts associating the aesthetic domain, the sensory world, with being alive, with proof of life, with the effect of feeling alive, most to our point. He talked about the free play of cognitive power. So one of the things he discerned the aesthetic dimension from the rest of the world, rest of the sort of feeling world, was that the aesthetic domain it had an immediacy, an immediate effect. It was not a means to another end, which is so much consumes our daily lives. We do things all day, every day, as a means to some other end. Always this sort of future orientation, which gets at a lot of the problem of being a patient facing the end of life when you don't have much of a future to plan into. We have not exercised the muscle of immediacy, of living now. This is enter the realm of meditation, but also enter the realm of the aesthetic domain. And by the way, a lot of meditators, what do? You turn to the breath. You feel your breath. That's what grounds you. That's what embodies you. That's what tells you you're alive. Okay, so a lot going on here. But Kant's really, the big association here is he starts setting this thing up as something that exists for its own sake. Back to this idea of how do we carve out space for just being, not as some as leverage towards some future moment. All right, and preserves the mind in calm contemplation. That was another quote of his. So not a sedating effect. And those of us, I think a lot of us deal with in ourselves are patients who want to be conscious. But because of their pain burden or symptom burden, we have to load them up with medications that dull their senses as a side effect. They may take away their pain, but they lose also the consciousness. They lose the interactivity. And that's a side effect. This afternoon I got called over to Oakland for a patient of mine from clinic who was invoking palliative sedation. His bodily life, his senses were only sending him signals that were obnoxious. His body was starting to was anything but a pleasurable thing to inhabit. He was done with life because he couldn't feel anything but obnoxious signals. He was done. So what we do here in this situation is we sedated him. That's the best we could do. I couldn't prescribe aesthetic therapy for him, of course, and it was too late. So I guess the big point here is to think about the aesthetic domain as something which enlivens us and helps us feel alive. Okay, I'll keep repeating myself because it's important. All right, there's Justin, the guy who helped me with these slides. He's my roommate from boarding school. And a really fascinating guy. We'll talk about him another time. So Kant's really great stuff, but Kant talks about art and the aesthetic domain as this very rarefied world. Like, Justin here checking out a painting in the Louvre, right? So this rarefied, very special, you have to travel these distances to experience them. And in the Enlightenment kind of way of thinking, many people didn't even possess the power to appreciate art. There was an elitism to it. There was this rarefied sense to it. But what about the sunsets and the daily experience of being alive? Why would we cut ourselves off from those aesthetic experiences? There's no need to rarefy it. This guy, John Dewey, comes along, a big American philosopher, and one guy who was the head of the American Philosophical Association as well as the American Psychological Association. He bridged the two. A very important figure in early 20th century thinking. This article actually talks about him as one of two great things America's given the world, the other being jazz. He is a stud. He's an amazing thinker, but he's extremely accessible. So what he gives us in this book, Art as Experience, in 1934, he talks all about aesthetics. But he explicitly counteracts Kant, says, yeah, Kant's onto something, the immediacy of it, the being for its own sake, the life of the senses, but he takes it out of the museums. He gives us access to this idea that we can have an aesthetic experience anytime, all the time, and that it's not the stuff of someone who's hyper-educated. In fact, if you think about it, the life of an animal who aren't preoccupied too much with frontal lobes are finding their way around the world by feeling all the time. All right? So this is not a high-level thing. This is a base-level thing. By the way, his book is dedicated to Albert Barnes. And Barnes' collection in Philadelphia is a very famous story. And one of the things he learned from Albert Barnes was this everyday experience of art. Now, Albert Barnes had this ridiculous art collection, an amazing art collection, but he insisted on showing it in a certain way that museums would never do. I mean, he would put various artworks together that had nothing to do with their historical significance. He would also lay in these sort of other objects of interest. And he was just trying to break up the normal sort of museum experience. So, in John Dewey's world, we have access to this aesthetic dimension all the time. Film, even certainly music. But baseball games, things like, and you think about our patients when we ask them, okay, given what you're going through, given what the time is short, what's important to you? And what do we often hear back? Well, I just want to watch a baseball game with my family. Or I want to have the cookie again that I've not been eating for health reasons, whatever it is. But it's very often some very simple bodily thing that's some very sweet, immediate thing, right? So if we need more proof, you can read John Dewey, and he can sort of justify all these instinctive thoughts you might have. But cartoons, too. This was his phrase that I love. The aesthetic dimension is anything that intensifies the sense of immediate living. How perfect, right? So when time is short, tick-tock, the clock driving us mad, whatever can keep us present in the moment and reward us for doing so is A-OK by me. And for us as clinicians, this is this whole other world that we might have to offer. There's a lot of work to be done. But again, this idea that anything that intensifies the sense of immediate living, no means to some other end, being here now. Okay. So that sort of gets us through the philosophical justification, sort of the philosophical history. But again, I keep pointing us back to our intuition. Like, why do we spend so much money to live in the Bay Area? For me, it has a lot to do with the senses, the light, the food, the beauty of the Golden Gate Bridge. That's why I spend so much money living in this crazy town. And I don't, never mind San Francisco. Think about your own lives. Where do you go to vacation? You go to Muir Woods, or you go to a cathedral, or some place that makes you feel this simultaneous. Well, I don't mean to put words in your mouth. I go to these places because I get this simultaneous experience of feeling so happy to be alive that I can feel and see and experience these things. But I'm simultaneously so happy to be alive that I could also let go of this bodily life. There's this weird dual thing that happens. And I think I hear myself say this phrase, oh, I could die today. That phrase is really potent to me. And when I say that, again, I'm usually in Yosemite or looking at a sunset or hanging out with my dog or whatever else it is. But it's because of some immediate sensory experience that I'm having that makes me feel that way. I guess I'd just encourage you to ask yourselves that very question. Where do you hear yourself say, I could die today? Not because out of some retreat, like screw this planet, I'm out of here. Because I love it so much, I'm so clearly a part of something larger. Isn't that wonderful? I can let go now. I don't think we're going to be able to do all of us get there ourselves and stay there, and I certainly don't think we can mandate that for our patients. Of course we can't. And we have to be very careful, and that's why I want to sort of take the wind out of this beauty piece, too. I don't want to suggest that we can mandate this very beautiful ending for everybody. For some of us, it just needs to be gnarly. But I would love us to find ways to offer at least the possibility through this aesthetic dimension for people, so it's not just a lack of access. Okay. So that's the living part. Dying. What was I going to say about dying here? Oh, that's the hazard. So I don't put any much text on my slides because then I don't read them. But then sometimes I lose my place. But dying. So I would say living now, if John Dewey and others have given us this sense of what it means to be a human being by way of the senses, and that's living, that's this beleben, this is quickening, this enlivenment. Well, what about dying? Well, okay. So the Unified Determination of Death Act, or what I can't remember the exact language, but I think that's it. What is death? Well, the simultaneous cessation of respiratory and cardiac function or the total loss of brain function. Okay, great. So my lawyers and my family and the pathologist can know I'm dead. That's useful. But when is life over for me? When is it? And that's a very personal question. And for me, for my money, I'm pretty sure whatever else death may be when I get there, if I can no longer take anything in, if I have lost any sensory contact with the world, I'm pretty sure, for me, that's death. Okay, so I would encourage us to think about what death is for ourselves and the surprisingly subjective nature of that question. So here's a painting by Edvard Munch who kind of gets at this point. So living and dying by way of the senses, well, he's an aesthete as a painter, for sure. And if you guys know his work, it's very often extremely colorful and expressive. He was very ill as a child. This is a painting by the deathbed, hearkening to his own experience with fever. And you notice, the bland coloring, so browns and pukey green, the expressionless faces of the people looking down at him. There's no window. There's nothing for him to look at. He's essentially cut off. All right? He's essentially cut off from his sensory experience. And for him, that was a terrifying moment. And for him, that was a deathbed. Anyone recognize her? I think I just heard you say it. Hey, I won't belabor this. Florence Nightingale. So in this book, 1859, still in print, by the way, Notes on Nursing. Much of that book is devoted to talk about form and light and color. That's where she's pointing nursing and caregiving to attend to those things. And it's as true today as ever. And she spoke directly about it, that this is not just an aside to make things pretty as a distraction or sort of for some smaller purpose, but that had a direct effect on the person, on the body, on the will to live. There are studies around environmental psychology that point us to if you're in a hospital room that has a window and you can see a tree, you might get out of the hospital sooner. You somehow relating that to health. And okay, but I don't need any proof that I might live longer, get out of the hospital sooner because of attention to the sensory experience. That's a more intuitive. That proof is not necessary. Again, I can just look at my own daily life and how I find meaning. And again, the senses light up. Okay, so that's much of the sort of content of the talk today. The rest of some of these slides are some things that are going on in the architecture and design world that way. Of course, architecture is just one piece of some sensory experience. It's a major one. This is some notes on a hospice garden for children in the UK. This is a day hospice in London, a daycare unit in London. And it's just nice to see. In the UK, have you guys ever heard of Maggie Centers? It's an interesting, there was I can't remember the name now, but an architecture historian and critic and husband-wife couple. And the wife died of breast cancer. And they talked very much through her course of illness about the sort of ugly nature of the healthcare bricks and mortar and how they wanted to do something differently. So they enlisted a lot of their architecture friends to build these Maggie Centers that are now dotted all over the United Kingdom. They're not places you stay. They're sort of resource centers where you can go visit, but they're striking and beautiful. This is a hospice in Denmark, in Djursland. Note the windows, and it abuts on the town. It looks out across the national park to the water. And the view is, every room is oriented in that direction. There's an experience. Alvar Aalto, as an architect, built a sanatorium for tuberculosis, and he noted that most of the time patients are laying flat. We may be ambulatory and vertical and standing up, and we look this way. Patients are often looking up. So as is down here, there'll be huge light wells in the ceiling and interest for those of us who are in a bed looking up all the time. These are just more examples. For some reason, Robin House. Some reason, what's very interesting to note in what the state of the art of hospice architecture these days is very often the best stuff is to be found in the pediatric world. I don't know why the kids have all the fun. I guess we can justify kids having this sort of sensory stimulation more than we can for ourselves, which is a shame. Maybe we can change that. I mean, look at that picture, all that glass and the water. And can you imagine what I love? Like a group of physical therapists is starting to volunteer at Zen Hospice. This idea of movement as a pleasure in its own sake while you still have something to move. What a beautiful thing. The idea of being in water, again, not as some means to the end, and not of exercising so you will have a lower cholesterol, but for the pleasure of feeling water on your body. What a joy. By Abdullah Children's Hospice in Kuwait. This place is amazing. This is a 22-year-old female architecture student came up with this building. And the basic design brief for her was, I want to build a hospice house that people wanted to be, where people wanted to be. And most of us think of a hospice as the last place you'd ever want to be. And I think at Zen Hospice, just the fact that we're in a little Victorian, it's lovely. And it's nothing like what could be created from scratch, but just the fact that it's not a hospital and it's not a skilled nursing facility, and that people don't mind being in the building. We have events in the house, and people come through the house. And it's a sweet little way to pierce the veil, to just interrupt the gap between most of us feel between living and dying. And just by virtue of being in the house, it can be a way into the subject for people. I see it happen all the time. It's beautiful. So this is all by Abdullah, the door for kids. So yeah, there are more. This place is crazy. I mean, look at it. Anyway, so that's it. So there are some examples out there of people paying attention to the aesthetic dimension. Again, plane tree, this very building, very exciting. But it does seem to me, as we as caregivers look for ways to help folks to the end, and for death not be so much of a retreat, but as a moment where we sort of dissolve into this beautiful world around us. I think there's so much that can be done through this aesthetic dimension. And I just want to introduce that subject here for future thinking and to sort of just prime you guys to consider this dimension as you think about your own role as a caregiver and your own role as a human being. And that's it. So time for questions and discussion. And questions. Oh yeah.
This hour with us in a very aesthetic living room.
Yes.
I was hoping you could just speak for your own process. I mean, obviously this is so important to you, and what we often find ourselves culturally doing as palliative care physicians in the way that we manage suffering is to take away sensation. Mm-hmm. And I think prior to this talk, I didn't think of it quite in the same way as I'm sure your process is, and I'd love to hear how you balance that.
For myself clinically or for myself as a patient?
Go for it, either way.
Well, so professionally, I'm thrilled to work in a place like Zen Hospice's guest house. And I will be very naked. My hope would be someday that we could build a place from scratch in the Bay Area that gets a little bit more to the potential that we're talking about. So I'm fascinated by the bricks and mortar. And in between now and building such a place, I'm thrilled to have this little Victorian to play in and to work in. That's for sure true. There, one of the places that gets the most attention is the kitchen, which is a little surprising. If we only have 6 beds at Zen Hospice, and many of the people who are residents there can't eat much of anything at all. But we notice that we are often cooking for smell or cooking for symbolic reasons. So there's all this attention that goes into the kitchen, which is so beautiful to watch it play out, and beyond this sort of means to end of sustenance. And I think that if you ever watch this TED Talk, it's not up yet, but the TED Talk gets at this little this is much the subject of that talk. And I started thinking about what we human beings do if once we turn our attention, once we accept something as a fact in our lives. Like, you think about any sort of basic human compulsory activity. Okay, the need for food. So we as machines, we burn energy, we need to replace it, so we've got to go get food. And for the bulk of history, scrounging for food has been a major ordeal. But eventually we sort of cop to that as a need, and look what we've done with food. Once we sort of allowed ourselves to start get playful with it. Bless you. Think what we do with food now, cuisine. I mean, yes, it's sustenance, but especially in this town, boy, do we play with that. Or the need for shelter, architecture. We could just put 4 tent poles in a canvas. I mean, we could satisfy the shelter piece, but the potential of architecture and design is huge, and we as a society tend to value that. It hasn't so much been applied to hospice or end of life yet. Or you think about time, the clock, and how it ticks and talks. Well, what have we done with that? How do we play? How did we accommodate the clock? Well, we invented music. So there's all these beautiful. So if death is is a necessary part of life, once we as a society cop to that, then we can get playful and we can get creative. And then we can think about dying as an experience, and we can start designing for it. So it's mostly a potential. And I would just say, lastly, from my experience as a patient, I have to say, so I lost some limbs as an undergraduate, in the first couple years, and the whole idea of rehab, even the language of rehabilitation, is the idea is, the implication is, well, the goal would be to get back to where you were before some event. I find that's a discouraging goal, because you can't get back there. These limbs ain't growing back, right? And by the way, for those of us who live with some sort of illness or traumatic event, if you make that the goal, you might very well accidentally cut off this idea, the learning that can happen, the transcendence that can happen, and all the beauty that can come from it. So in my own experience as a patient, I remember very clearly a couple years in, it was a big moment for me because I was studying art history and architecture and stuff like that. So I was thinking about modern architecture and how it sort of, and Louis Sullivan would take the applique off the building and reveal the structure of the building and celebrate and delight in the structure of the building rather than trying to cover it up. And the standard back then for prosthetic legs was to put this foam, fleshy colored foam thing around the leg so you could kind of pass, And that just never works. Simulacra never, it's a design flaw. If I'm designing something to pretend it's something else, that's a shame. That's not celebrating it for what it is, So a big moment for me was taking those foam covers off the legs. That was a really therapeutic moment for me. And at that point, I knew I had accommodated this disability now. I had reframed it. This was part of my life, and I was playing with it. So I think it's a very long answer to your question, but there you go.
Yeah, I think what your talk conjured up for me in thinking about my experiences with my geriatric patients, if you ask people about how they live their life now, they talk about living one day at a time. And you could say that's an adaptive response to possibly the change in goal orientation. In fact, when you ask people about goals, I remember one person I interviewed said, the most I do with goal setting is trying to figure out whether to renew my Time magazine subscription. And I was hoping you might be able to reflect a little bit about your thought of this sense of immediacy that comes with either advanced illness or aging, and how that might impact on us as we contemplate our own aging process.
Yeah, thank you, Ken. I mean, I think about, it's a shame that it takes something for like an advanced illness or the idea that we're dying soon to kind of wake us up to the power of the present moment. And without getting too airy-fairy about it, I mean, it truly is all we have. We have right now. Who knows what's going to happen tonight, etc. But for most of us, it takes some disruptive event in our lives to help us realize that and the potency of that. And for many of us, myself included, that took, I needed to lose a couple limbs. It was a big smackdown. And it pointed me to the folly of planning, of making this, of pretending to orient myself towards this future that may or may never come. That's a little simple-minded because, of course, it's practically irresponsible to not plan. It is considered, I do it all the time, it's considered irresponsible to not plan. And so we do, there's a little tension there as a society, which is why it needs to be disrupted. There needs to be most of us need an excuse to be present and think about our lives now. And for many of us who deal with some form of illness or trauma, once the grief process is done, and once you turn your attention from what you have lost to what you still have, that basic shift is so potent. Because no matter what state you're in, you're likely to have so much still. I mean, if you have just one sense left to cater to, the trauma, the torture can come from just realizing all that has lost, that you don't have. If there's enough time and enough encouragement, enough support, you can get to that place where you realize what you still have and delight in it in the moment. I'm not sure I'm answering your question, Ken, except for to say that it's not surprising that our elders have learned this lesson. There is a wisdom in it. And that people who live with serious illness, because again, that smackdown, that external force that just says, nah, you're not so big. You're not, the world isn't what you think it is. I love to go out to the desert and feel really, really small, ever since my injury now. That proportionality with the world around me, I think, is so potent and so helpful. Especially us as physicians and clinicians, the world is looking to us to have these powers, to do these things. And it can be a little bit overwhelming. And we can really get out of shape, out of size, disproportionate. So I love anything that reminds us about our insignificance. Yeah, all right.
I'd like to ask about this concept of livening or animation or quickening that you described, because that is how our senses awaken to the possibility of the delight you reference. But I'm also intrigued by its potential role in substance abuse, which is a way to sort of achieve that heightened sense of being and experiencing life, or certain psychiatric illness, mania, pick your favorite, where there's either sensation that is powerful but perhaps not functional or contributory toward this calm consciousness you describe. How do we reconcile all this? How do we embrace the good while recognizing that at times perhaps it is counterproductive to enhancing well-being?
Yeah, it's a really good point. And it's fun to talk about this subject here as a corrective, because the senses have been somewhat abandoned and abused in our ideas of health. And so it's very easy to advocate that we return to a world of immediacy in the life of the senses. There could be a lot of irresponsibility in that, and we can get a lot of trouble. Those of us who lived through the 60s maybe could have some anecdote and stories about how a lack of understanding of the sort of long-term effects of chasing those sensations. So I think I don't have a great answer to. I would note the cautions, and I'm not suggesting that we all abandon a life of principle or are planning entirely to become purely aesthetes and just jump from one sensation to the other. It's more that I'm asking that we start paying attention to the sensory access that we have, that we just steamroll by all the time, and sort of paying attention to what is now. And if we get our mindset into if you start looking closely and all the rewards that come from paying attention closely, hopefully, maybe, theoretically, you'd have a counterbalancing effect from chasing these extreme sensations and for it to need to be bigger and bigger to overcome your numbness. I think that's what can happen in substance abuse. It takes just the trigger needs to get larger and larger and larger. When in fact, if you are taking sort of be here now, the idea of just delighting and feeling anything at all, the joy of sitting in a chair and resting your feet, whatever it may be, the joy of being in a car that's moving across the planet, whatever it may be, that kind of attention to John Dewey's idea of aesthetics is this very everyday thing. That's got to be our goal. rather than chasing sensation. So it's not a great answer there either, but there is certainly caution, and that's good to note. Again, it's fun to be the advocate for this other way of thinking, but there are cautions there too.
Fair enough. Thank you.
Yeah.
Thank you so much, BJ. That was inspiring. And it just makes me a little bit sad to think of all the patients that I send home on hospice who don't have access to the 6-bed Zen Hospice. And I'm curious as to whether or not you are planning, and I hope you are, to come up with some kind of a, I don't know, manual tool, something that can be disseminated to patients going home on hospice who are maybe less able to access these types of strategies.
Yeah, I wish I liked to write. I mean, I think, you as a writer, I know and a dang good one, Jessica, it's not easy work. But there was certainly some interest among us as a group to get something down in something of a guidebook, to start fleshing out. I mean, I think as a field, right, hospice and palliative medicine, again, is very young stuff. So it's not surprising we haven't gotten to so much of the cultural context and idiosyncrasies between us and among us, and we're so far away from all that it could be. But I do think embracing this aesthetic dimension is a nice next step. So yeah, there's some talk of us trying to write some of these things down. Justin, my old buddy who's in that picture, he and I would like to write if we get around to it. So, yeah.
People need it.
I will say one more comment on that, Jessica. It makes me think of both a couple of the questions here. Sometimes I've noticed that once we start looking for, it's happened on multiple occasions where family members felt like they were supposed to be looking for this major transcendent seas parting moment, some just, and reminding them of the joy of a chocolate chip cookie, or that your dad can still watch the Giants game and it's plenty to just celebrate that because that's all he really wants to do anyway. It doesn't need to be more, it doesn't need to be bigger. So I've noticed a few times where we've just, the power as a clinician was just to bless that experience as worthy. That's kind of all it took.
Yeah.
So that happens actually with some frequency.
Thank you. I just wanted to ask if you could expand a little bit on your discussions about feeling and aesthetics, because I've got a hunch most of us providers who came to listen to you today are pretty connected. But what advice could you share with other people about how to better connect with our own feelings and our own comfort around connecting with our patients?
Yeah, it's tough. You're right, this is a self-selecting crowd. This is a friendly crowd, and one who are predisposed to some of these thoughts, maybe all of them. This is, I think, why I see a lot of people. I think meditation is a good analog to this. What helps us just pay attention, essentially? What can reward us, what helps us pay attention? Again, there's so many signals that pull us out of paying attention. So I watched many clinicians and increasingly younger people come wanting to volunteer with us at Zen Hospice Project, looking for some countervailing force to help them just be okay in the present moment. Because that seems to be, in a way, getting harder and harder to do. So I do think some sort of mindfulness or meditation practice can be really potent in this way. For me, that can be a walking meditation. I like to get out in the woods. This is sensory stimulation. Sure, paying attention to my breath, okay, but for me, it's more an externalizing process of paying attention to what's around me and to taking on just watching my field of vision and seeing everything that's in it, or spending time out in the woods just listening for every sound. Is basically a deepening. Just paying attention to all the things we just glide right past. So I think all of us, I would just encourage what's happening, what our society seems to be gravitating to already. Again, a meditation sort of point of view. And all that helps us do, again, is just be okay with what's happening now and helps us sit with suffering. And I think the discipline for us as clinicians is catching ourselves when we hear ourselves try to leap to fix something or leap to the prescription pad. There's all these subtler shades of gray in between us and morphine that could be helpful. So some of it is that sort of discipline of catching ourselves, and to inform that discipline, I can't think of anything better than a meditation practice.
Dr. Miller, would you comment on being able to die at home. I ask that because when my son was suffering from a stage 4 lymphoma and treated for about a year and a half, the only hospice at that time was in Marin, but it wasn't in a building. In other words, it was an opportunity to support someone or someone's with dying at home or bringing a loved one home. And we were able to bring our 14-year-old son, who had been treated at Stanford for about a year and a half, home to die. And the aesthetic of that, I'll use your term, or the beauty of it, was immeasurable. That we were able to care for him in our home, in his room, where everything was familiar, where what I would hope to say our beauty of our home interiorly really allowed for a very peaceful, beautiful death that his sisters and my husband and I were able to be there with him. And I just wish you would comment on that aspect of hospice.
Well, amen. I mean, I take for granted that most of us and most of society continues to report wanting to die at home as the goal. And while I love our guest house, and I'm so glad it exists, and Coming Home Hospice and other places, not just Zen Hospice, exists for folks who, A, don't have a home, for cultural or personal reasons don't want to die at home, or the family's burned out, or whatever else. But frankly, those are largely the exceptions. Most of us, I still think, would wish to die at home. And that remains the sort of goal of most hospice agencies. So I almost take that for granted in our conversation. So just to be really clear, I mean, dying at home, again, this aesthetic piece, it doesn't mean dying in a museum. I mean, for some of us that may do it. But somewhere where we feel safe enough to pay attention to our senses, where we're comfortable enough to do so. And some of that may be familiarity, but whatever it is, it's extremely subjective. I can't tell you what gives you that immediate sense of living. You can tell me, though. And so this gets us back to the orientation of hospice work, of always contextualizing the work in that person's wishes. For many people, that's the home. And should be, needs to be, and we have to pay attention to how people die at home and keep making that possible. I worry that that's getting harder and harder to do. I see people coming to us at Zen Hospice who just couldn't die at home for a number of reasons. So, but to your point, home is, yeah, I'm all for home. Yeah. Yes, I am.
My name is Patty Perkins. I'm originally from New York, and I was an HIV primary care provider in New York City before we had protease inhibitors. I've been helping a friend who was my patient 16 years ago in the liver transplant system in this hospital. And I'm also a financial donor to this hospital, as is most of my family, as is his family. And I just want to make this point to all the clinicians here. There is a reality that I think some of us who've worked at San Francisco General and UCSF or Beth Israel, where I trained, or Hopkins, where I also trained, that many of us kind of forget here. Many of our patients, especially on the transplant unit up on the 6th floor, are living in very nice and somewhat very upscale single occupancy hotels, not always in the Tenderloin, but the kind of family network that was really necessary to sustain a hospice at home no longer exists. Not the way that we had it in when HIV was primarily an MSM phenomena in both New York and San Francisco. My friend actually did enroll in a wonderful hospice with this hospital for 13 days, and we did a marvelous job with him. We had wraparound sort of 16 hours of care. One thing you do learn as a New Yorker and a former Bostonian with a father who's a city councilman is how to hustle, 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 hustle. And even with all the hustle, 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 the Roman Catholic diocese that owns his building and his landlord were very discomforted with all these people coming into my friend's room. All these people who, not just family members, but nurses from the hospice and other things like that. And I think that there's just a reality to your point about how we actually try to die at home that many of us would like to encourage our patients to do, but we may not be able to actually encourage them. And we certainly can't necessarily encourage the well-meaning friends and family if the friends and family can't actually get a landlord to allow this to happen in this city at this time in 2015 when we have a 0.02 occupancy rate for rentals. And now I will get off my New York City soapbox and cede the floor.
Well, thank you, Patty. I'm with you. It is, for a number of reasons, it's harder to have a home. It's harder to die at home. Yeah, and I I will let you say it best. Anybody else, guys? All right, guys, thank you so much.